Welcome to the Heart of Healthcare with Dr. G. This is a podcast that is unafraid to address current issues regarding top healthcare needs and concerns. Welcome back. My name's Toni Kiskin. I'm your host, and Dr. G's with me today. I'm so excited. Pull up a chair, grab your coffee, some tea, whatever it is that you drink, and join us. We're just going to have a conversation today. It's a tough topic, and that's what we do here. And but we're going to touch on it. And
we're not afraid.
We are unafraid. That's exactly right, Dr. G. So we are talking about pain management in hospice care. And we've talked a lot about hospice in season 1, or actually episode 1. I'm already into seasons, hey.
Speak it.
Yeah. In episode 2, we talked about palliative care. So today we're going to talk about some pain management in hospice care. But before we get started, I want to go ahead and read our scripture for today. And it is from Romans 15:13. May the God of hope fill you with all joy and peace as you trust in him, so that you may overflow with hope by the power of the Holy Spirit. With that being said, we got actually a question in, Dr. G, from New York City. This is from Jean. And Jean's question to us is, can I continue to receive treatments to cure my illness in palliative care?
Oh yeah, Jean from New York. Thank you for emailing us. So of course, we actually touched on that on episode number 2 about palliative care. And we talked about how palliative care is that extra layer of support for you while you're receiving curative treatments if you have a serious illness or chronic disease. And we touched on how the support that you get from the palliative team, be it a community program like we have here at Destiny Palliative, where I'm the palliative director, or if you have an outpatient clinic, they're going to help you with your symptom management, care coordination. You have the whole interdisciplinary team to help you. And that actually reduces stress, the stressors you have from your disease, and it actually optimizes your treatment. We use the example of the person who had cancer, and though that person was hospice, I still use it as an example. This person had lost 90 pounds from having constant nausea, vomiting, not being able to eat, then getting tired. So all those symptoms, nausea, vomiting, fatigue, weight loss, those could be addressed with the palliative team if you're still undergoing treatments. And so you'd want to get that optimized, because these things can affect your functional status. And those are some things that are important when we're making people, seeing what people need. So definitely yes, all that to say yes. I got a little bit too technical there, but go to the website Get Palliative Care, and you'll be able to do a little bit of research in your area and see if there's some folks that can help you.
I think that's a really good answer. And the number one thing we really want her to remember too, and you brought up some really good points, is that we want her to be able to, or whoever she's speaking of, to be able to really get the treatment, aggressive treatment they need, and still be able to manage the symptoms so they can keep going back and forth. And you answered that so well, and that really helps a lot for them.
Yeah, and then the hospice is when you have decided to not do any more of those treatments. We just had an admission last week where someone chose to not do it anymore, and so they just moved on over to the palliative program. Sometimes folks are getting treatment and it's not working. Let's say the cancer advances, so then they go to hospice. But palliative care is not hospice. I want to be clear about that. Hospice is a special type of palliative care when the person is not getting curative treatments and they're just focused on symptoms, and they likely have 6 months to live.
Absolutely. So great benefit, great question. Also, she wanted to know, Dr. G, is if Medicare paid for this. And Jean, you happened to mention that you were under 65, so Medicare would not cover this benefit, and it does not recognize palliative care right now. So if you were 65 or older, it would cover under home health, which we talked about in episode 3, and it would be able to cover that. But for palliative care right now, they're not recognizing it. She also wanted to know if Medicaid would pay. And in your state, you might have a program where Medicaid could pay. I'm not that familiar with New York. Here in California, we have a program under IHP, and that is our Medi-Cal program. It does actually cover for palliative. It's called the MyPath program. So I think that you might be able to look into that a little bit more for yourself. So, all right, well, great question. I'm so thankful that we're getting questions. It makes me feel really good, doesn't it, for you, Dr. G?
Yeah.
Absolutely. All right, well, now we got to get to the job at hand. And that job today is to talk about pain management in hospice care. We mentioned that this is a tough conversation to have, but pain management in hospice care is really the primary goal. And I'm going to let you talk about that, Dr. G, because you are very knowledgeable in understanding how to keep the patient comfortable in palliative, in hospice care, and really what it is that we're going to be needing to do there.
Right. Well, this had become the fifth vital sign in the past years. That's kind of controversial. Everyone knows about, the opioid epidemic we're in. So we're going to touch on some topics. I want to say just right off the bat, we are talking about specifically hospice and palliative patients. While we will touch on some things, this is not for the general public for pain management and things like that, but we will touch on those things because it's important and we're not afraid, right? Pain, actually, I'm CAPC designated in pain management, and CAPC is the Center to Advance Palliative Care, and they actually have good modules to help physicians and other providers to become versed and comfortable in using opioids. For instance, opioids are the cornerstone of hospice and palliative care. And again, though we're in an opioid crisis, that is not what we're talking about. But we'll get to that in the second segment. And so the fifth vital sign, pain. So I know you had some things you were going to go over and how we measure pain.
Exactly. Yes.
Like that. But it's one of those things that are important to manage when we have our patients. I actually have been advocating on Twitter and other social media for ACGME or somebody to mandate CAPC so that more primary care providers can be versed and comfortable in managing these things instead of, like we have Jean here. What if she doesn't have, someone in her area?
Right.
She should get that primary palliative care from her regular doctor, and they should feel comfortable to be able to, prescribe these things.
Right, give her the pain management that she's needing during these aggressive treatments,
Yeah.
for sure. Well, you touched on the scales, and what we do here at Destiny Hospice and Palliative Care is we actually use the pain scales that are out there, and they include the 0 to 10 numeric rating scale, the Wand-Baker Faces pain rating scale, and then the FLACC scale. That scale is more for those folks that are not able to speak. Maybe they have a dementia, an Alzheimer's, that kind of a thing. So we use that along with the Wong-Baker to kind of more the facial grimacing, those kinds of things, to kind of really see where they're at in their pain management issue. Dr. T, if we wanted to go over some of the signs and symptoms of pain while you're assessing or communicating with them as a physician, what is it that you're looking at, do you think, with them?
So I'm looking at if they're restless. I'm looking at, you can see, like you mentioned, their facial expressions. I can just tell.
Yeah.
It's not something that that's why you have a doctor, that's why you have a nurse. It's not something that I can tell the person, like, so when you're in pain.
Right.
So we just kind of have to ask the history. We look at you and we know.
Right.
No, it's just a part of it.
And that's so true. What happens here in hospice, and we see it an awful lot, a lot of times family members are not comfortable giving the pain medication. And as the nurses go in, just like Dr. G just said, they're going to note, wait a minute, there's some grimacing going on. They feel really rigid. They're definitely withdrawing from their family. And the family doesn't understand why that's happening, but oftentimes it's because they are in pain. And as a physician, that's what those kind of things that you're looking at as well. So we really try to get the family members more comfortable in giving the pain medications as prescribed and knowing that we're going to be able to keep these patients comfortable. And that really ultimately works well, wouldn't you say, when we give them that education and help them to better understand?
Yeah, because sometimes, again, we're all affected by, the opioid epidemic. I want to take a moment and acknowledge we've had a lot of deaths. It's affected everyone. It's affected patients, it's affected doctors. There have been patients who have not been able to access their medicines because, people are afraid to prescribe them. There are physicians who are afraid of getting arrested for overprescribing. When the CDC update came out for the opioid epidemic, that's when everyone kind of got scared and cut down on the prescribing. Then the CDC had to come back and give an update.
And that's just recent, right? Like 2016, and then
2019 to say, hey, we can't misinterpret the guidelines. These guidelines do not apply to people who are in palliative care or in hospice. And so unfortunately, everyone is affected by this. I felt, the fear of prescribing and having to look on cures and all this stuff. And I do want to acknowledge also there are folks that struggle, with addiction. Again, we're not talking about hospice, but in the general population, addiction is a disease of the brain. And there's a huge stigma attached to folks who are dealing with addiction. And so it's just a challenge. So we're all having to deal with it, and we do the best that we can. But in hospice and palliative care, we're using these medications to help get the people comfortable because they have life-limiting illnesses most of the time.
Absolutely. A lot of families get really nervous. We talked about this just briefly in our first episode regarding hospice, but when they hear morphine, the word morphine, or they hear the word methadone, or the anti-anxiety medications, those kinds of things, they get really nervous sometimes about giving them to their loved ones because they don't want them to be addicted, or they have other concerns, worries throughout their family. Do you see that very often in what you're doing out there in the field?
Yeah, I see it. And so that's where we come in, the physician, hospice medical director, palliative medical director, and the nurses. We educate the family, because I have been in circumstances where a family is like, I don't want to give it to them because they used to have, take it too much. And so we educate them on the proper use of it, the proper doses, reassure them that we're always given the lowest possible dose to manage the symptom at whatever they state they're able to take, and always in line with the goals of care. So that's where the education comes in, and we're not limited, by 15 minutes with someone. I've spent 3 hours at a home before when it's needed, to get everybody comfortable and educated. So what's disheartening is when we have folks who can't access the medications they need. I remember a gentleman, he was testicular cancer, and that's a disease of young men. So if there's any young people listening, I don't want you to think that we're only talking about, our Medicare folks, people at the end of their life. Testicular cancer is something that can be affected, that onset 20 years old.
Yeah.
So this was someone in their 20s, and it had metastasized, and this person was unable to get their prescribed medications from their palliative physician.
Wow.
And so this person ended up being hospitalized for extended days. I remember we even had to use palliative sedation because it was so severe.
Oh.
And so back to this is affecting everyone. It's a tough topic. It's a tough topic.
It really, really is. So what we really want you folks out there to really glean from this podcast today is that Pain management in hospice care is truly to help the patient to be the most comfortable that they can, so that they can have the best death possible. And that's really what we strive for. All of our doctors, Dr. G, the doctors that work here in hospice, our nurse practitioners, our entire team, we are working very, very hard, because we get one chance at this, one chance to make a difference in that person's life, to help them to be able to be comfortable and to be able to die in dignity and surrounded by their loved ones, their family members, those folks that mean a lot to them. And if someone is just, in horrific pain and struggling and having all of those different kinds of symptoms that go along with that, we've not done a good job. And that's what we want you to know, is that it looks very different when it can be done well, and it looks very different when it's not being done well. But you're a part of this, and you have to listen to your hospice team, you have to listen to your doctors and your nurse practitioner, those providers, professionals, in knowing what to do, which is so important. So the last part then that I want to talk about, and this is something that Dr. G and I, we know all too well. We see it a lot, the emotional and the spiritual pain. And oftentimes that can even be more ravaging on somebody than even the physical pain. And we can see that in families sometimes. Maybe there was a split in the family. Maybe there was something going on and some mean things were said, and now the person's not competent of being able to hear. A lot of that emotional and physical pain can really end up being, or emotional and spiritual pain can be really tough. But what's so great in hospice is that we're able to touch on that. We've got our chaplains, we've got our social workers, we're able to get in there, we're able to address all of those kinds of needs, and to really kind of take that away from the family so that they're not burdened, and kind of bring something to the table to help them to be able to better understand what can be done. Because the worst thing in hospice is we don't want anybody to A, have regrets, and B, feel like they could have done something more. And that's something we really do try to work with.
I'm glad you brought that up, because I'm studying for this exam.
Yes, you are.
So my mind is there. And there was a question on there that wanted to cover the topics. This is my book here, Hospice Medical Director Manual. But it talked about the concept, what you're referring to is actually called total pain. And so that the concept of total pain is when you have the emotional, psychological stressors and all these other things that could make the pain seem worse.
Right.
And make the medication seem like they're not effective. And so again, me having the freedom to spend an extra hour there to talk to someone where we can explore, the things that are bothering them, the unresolved conflicts in relationships, the things that have been left unsaid with distant relatives.
Right.
Sometimes people are waiting. They don't know why they're lingering.
Right.
They're waiting for that last person to come by.
So true.
It's so
I know.
Weird.
It is weird.
But also awesome weird. And so total pain. So the question that was there, I believe it was on the test, was the practice test, someone had a secret and whatever. So it touched on privacy. It kind of touched on all the things that we're supposed to be competent on. And the goal of the question was to show that you're gonna address it and let them talk to you and ask permission to involve the chaplain or the social worker, screen them for depression, anxiety, and things like that. So it's a whole comprehensive care that you get on hospice, and addressing total pain, because we know our emotions, we know that our stressors, all these things affect us.
Absolutely.
We know that. We had that lesson today, huh?
Absolutely. And it really does. It can really affect the whole person and everybody else around them. So I'm really glad that we got to talk about this topic today. And I'm hoping that it helps you out there as well. These are things that we have found to be helpful in talking to other family members. And we really just want to bring it to the table to you all today, and hope that you were able to enjoy it with your coffee, your tea, whatever you're joining us with. And we will see you at our next podcast. See you soon. Thanks for tuning in to At the Heart of Healthcare with Dr. G. Help us by rating us on iTunes. And don't miss an episode by subscribing on YouTube. And be sure to click that little bell to get notified about new episodes. We can't wait to see you next time.